like to introduce our last speaker of the day, which is Dr. Ryan Castoro. Dr. Castoro is going to be talking with us about symptom and pain management. He is a physical medicine and rehabilitation physician with MU Health. So thank you for being here today, Dr. Castoro. We're happy to have you and looking forward to your presentation.
Yeah, thank you for having me. It's a pleasure to be here today. Can you see my slides okay?
Yes, I can. Thanks.
Great. So, like I was saying, it's really a pleasure to be here today to talk to you guys about something that I study in my lab and also in patients, and is trying to better understand pain and pain characteristics in patients with Charcot-Marie-Tooth disease. And just by starting off, by way of disclosures, I do have a few disclosures here, but none of them are related to this particular talk that we have today. But overall, in discussion points, as I was talking about, I think about pain and CMT quite often and trying to understand it. And we don't have all the answers, unfortunately, but what I hope today, by way of this talk, is that we have the opportunity to educate you guys about what types of pain there are that you may experience, why you may or may not experience those types of pains, and what, if anything, we can do with it. And then at the very end, I thought it'd be maybe helpful to walk through kind of a paradigm as to the ways that I particularly think about treating or managing pain in patients with CMT. There is a very nice, somewhat precise definition of pain, and I think it's very interesting that the definition of pain defined by the International Society of Pain defines pain really as having both a sensory and emotional component to it. And the CMT and the things that I study are often related to the sensory or peripheral nervous system associated with pain. And when we think about pain associated with Charcot-Marie-Tooth disease, we often think about the effects that the sensory nervous system has. But all pain, whether it be good pain, meaning pain that's a warning sign, or bad pain, pain that you don't want there, has some emotional component to it. And therefore, not everybody's pain is similar. There are different ways to describe pains. There's different response to pain. So some of the things that we described today may be overlapping. You may have both types of things or may experience something very different. But hopefully this gives you some of the tools to be able to discuss these type of things with your physicians. And so leading off, getting off into our first question here, what are the types of pain that we see in CMT? And I think we can start off with a really nice guide provided by the Hereditary Neuropathy Foundation. And this guide, you'll hear me talk about it several times throughout this talk, discusses a lot about pain, both in the management of it, the origin of it, homeopathic things that can be done for it. It talks about the evidence and some of the side effects behind those things. There's a lot of utility, and hopefully today I'll outline some of that utility as we go through. But what I'd like to start off with highlighting is that when the Hereditary Neuropathy Foundation did a survey amongst their global registry patients, individuals, they found that almost 80% of patients had experienced some type of pain. But interestingly, only 12% of it was considered neuropathic, a small percentage of it considered muscular, an even smaller percentage of it cramps in the forearm, but a large percentage of it was muscle cramps and spasms in the legs and feet. Now, when we look at a broad picture of pain in CMT, there are some types and some variants of CMT that don't have any pain at all. They may just have a motor system. But there are some types of CMT that may have more pain than others. So if we look at one study down here on the left-hand side from Brazil, looking at a relatively small number of patients, but what they found was the prevalence of neuropathic pain and pain itself was around 84% in their group of patients. Other studies from other countries have demonstrated that neuropathic pain in particular is present in about 30 to 40% of CMT1A patients. But still around 80% of patients have some type of pain. So most people are commonly thinking about pain and neuropathy, they're thinking of neuropathic pain. And what I hope to introduce in the next few slides is the different types of pains we have. But before we get to that, I want to talk a little bit about why we might have pain and why pain might develop. So the types of pain that are often reported by folks with CMT are symptoms that are what we call protective systems. So for instance, you may feel a burning sensation in your feet. And we have nerves that are set to detect burning sensation. Some of you may feel like you walk on ice blocks in the morning. We have nerves that are meant to sense extreme or dangerous cold temperatures. We have nerves that feel pinprick. And these are very complicated systems that don't just involve the central nervous system, but also involve parts of don't just involve the peripheral nervous system, but also involve parts of the central nervous system. Oops, sorry. Hopefully you can still see the slides here. By going from the peripheral nervous system to the central nervous system, there's a lot of mismatch that happens. And so just because you have a peripheral nervous system disorder doesn't mean that the central nervous system won't continue to relay this abnormal pain symptom. And so really, pain is a complex disorder that involves the peripheral nervous system and the central nervous system, and also parts of our central nervous system that we don't fully understand, which is our emotional response to pain and the emotional context, which we understand pain. But these pain symptoms that we have are hyper or more than we would expect from a regular nerve to give off. So for instance, in the left-hand corner, there's a picture of heat showing pain. We certainly would want to know if we laid our hand on a hot stove, and we would want that signal relayed back to our brains that we can move our hands. But if we don't have the ability to sense that pain, then unfortunately we may not be able to do that, and that can lead to burns and things like that. But it's those same nerves that are causing the burning pain that you feel in your hands and your feet. Those nerves are hyperactive oftentimes, and that's why we get pain. Most commonly. There's a number of different reasons for pain. Inflammation plays a role, as we'll talk about in just a little bit. But oftentimes it's associated with a hyperactivity of the nerves that are sensing a particular modality, be that heat or pinprick or cold temperatures along with that. When we generally are talking about nerve pain, there's two types of pain to consider. And oftentimes, when we split things up in medicine, it may not be that important. But when we think about the origin of these two types of nerve pain in CMT and in other types of chronic pain diseases as well, it is important to understand the two branches of nerve pain, specifically when we're talking about neurodegenerative or neurodevelopmental disorders. The first is neuropathic pain. This pain is generally what pain associated with CMT is associated with. It may not always be that, but I think most commonly it's associated with pain and weakness, with pain that is caused by some sort of damage to the nerve, some sort of disorder that's caused the nerve to dysfunction directly on the nerve. Nociceptive pain is that pain that we were talking about before, pain that needs, um, sorry, looks like it says sharing and presenter view again. There we go. Hopefully that view is better. Um, And so this pain, this neuropathic pain or nociceptive pain is more of a protective response. It's showing if you hit your finger with a hammer, then that is going to cause some sort of response. You need to know that you just hit your finger with a hammer, and there could be some damage to your finger or to the tissue surrounding it, and that you need to do something about it. Now, it doesn't always need to be that dramatic nociceptive pain. Things like arthritis or sprained ankles, tendon pulls, these type of things can also be nociceptive pain. And there are differences in the type of the way people describe their pain. Most commonly, neuropathic pain is described as burning, electrical, or shock-like, usually following along the line of a nerve, oftentimes starting distally and working, meaning the furthest away from the spinal cord, so in the feet and our hands, and shooting back towards the spinal cord. But it can radiate anyway. But the importance is that it has this shock-like electrical burning and shooting quality to it. People can describe this a lot of different ways: bugs crawling on their skin, sandpaper being rubbed across their skin. Nociceptive pain, on the other hand, is better described as something more dull, more of an ache and inconvenience. It may change the way that you move. It may or may not be there all the time, but it doesn't have that electrical component to it. And this is more slides just highlighting the different types of pain. Nocioplastic is again more what we were describing in the earlier slides, where you gain a symptom of protection. So you may feel too much cold from the nerves that are supposed to sense cold. Sorry, I'm trying to fix the slides here. I don't see that on my end. I'll keep going. Marissa, I didn't see that on my end. So with these pain qualities, the nocioplastic is very similar to neuropathic. It's just the gain of some sort of symptom. But they do have very different qualities, and they can be described differently. And they have importance to be described differently because they indicate different origins as to where the pain is located. The third type of pain that the H&F had identified as being or the most common was muscle cramps and spasms in the legs and in the arms. These muscle cramps and spasms here on the left side, there's a lot of fancy words here, but it's all describing the differences between cramps and spasms. Cramp is what is most commonly felt in CMT, and these cramps usually involve one muscle. They may involve one or two muscles. They're almost always painful. They're almost always intense, and they're almost always a short duration. Whereas spasms differ a little bit from cramps in that they can involve multiple muscles, not necessarily near similar muscles, but these multiple muscles oftentimes are not painful. And that's really the difference between a cramp and a spasm. A spasm, though, is generally generated from hyperexcitability of the peripheral nerve, which does happen occasionally in patients with CMT, but is more associated with diseases of the central nervous system, whereas cramps tend to be associated with diseases of the peripheral nervous system. And when we're thinking about what are the causes of these on the right-hand side, here, there's a number of causes of cramps. Um, lots of people with lots of people with cramps, lots of people throughout the world have cramps. So 30–40% of people who don't have an inherited neuropathy who don't have an inherited neuropathy also have cramps. And there are lots of things that can cause it: electrolyte imbalances, dehydration, other diseases, rheumatologic disorders, new medications, alcohol, tobacco. All these things can elicit muscle cramps. And we'll talk just a little bit later about how all these things integrate into how we manage cramps and how we understand cramps and manage cramps as well. So what causes pain in CMT? As we talked about at the beginning, the neuropathic pain, what exactly causes neuropathic pain really hasn't been fully worked out. But on the left-hand side is showing you some possibilities of reasons that peripheral nerves may lead to causing pain. One of them we talked a little bit about earlier is that the nerves become excitable, meaning they're firing when they shouldn't be. So if you think about the light in your house, when you turn off the light with the switch in your house, you expect the light to go off. But in this case, the switch is being pushed down, but the light's still on, or the nerves still firing. And so that's where you can get too much cold, too much burning type of symptoms. There's also things that can happen inside the cell. Calcium can come inside the cell, but also the degeneration of nerves can set off a pain signal of inflammation that can cause pain as well. And on the right-hand side, not all neuropathic pain, on the bottom right-hand side, not all neuropathic pain is just due to simply having a degenerative or a neurodevelopmental disease. Some neuropathic pain, this is an image of an individual with CMT1A who has pretty severe pain, but what we see is large clumps of gray in the middle of the screen. Those large clumps of gray are the nerves. Those nerves should be about a quarter of the size, but they can get pinched as they run out of the neuroforamina, and that can cause neuropathic pain. So not all neuropathic pain is from CMT. And so there's times when the description of your neuropathic symptoms, the way that the burning can give us the way that the burning and the shooting is radiating, can give us some ideas on how we can identify what's causing your pain. Because sometimes if it's not directly related to the CMT, there may be some things that we could offer or do to help with that type of pain. But still, the more we learn about neuropathic pain, the better we'll learn how to treat it. Nociceptive causes of pain can come from any number of different reasons within CMT. What I'm showing here on the left-hand side is an image of individuals walking without braces and with braces on the bottom. And the old adage of the hip bone connected to the knee bone connected to the ankle bone is very important and true. As you can see, the individual on the top, when they're landing, their foot is kind of slamming on the ground. Their forces aren't directed in the right way, so they're not pushing off the ground the way they should. And this is causing strain on the tendons in the foot. This is causing damage within the ankle. And this, as many of you all know, the classic CMT foot abnormalities of pes cavus shown on the left-hand side, with a picture on the right-hand side and a radiograph. As we start to stress this already high arch, we can start to develop more severe problems over time. And this next X-ray here at the bottom is showing some severe arthritis that's developed around the joint to the point where that joint's not going to move the way that it should. So this certainly is going to be painful. The body is going to respond to it as if there's something harmful. And the type of pain that this most commonly is doesn't have that electrical type of component to it. However, if we can identify these type of symptoms early on and distinguish between neuropathic and nociceptive types of pain, it can help us identify places that we should be looking. Cramps are very similar in a way to the loss of sensation that we were talking about a few slides ago. The peripheral nerves start to degenerate over time. We're going to start at the bottom right with the turquoise nerve and the red tubes. These red tubes are muscles. The turquoise branches are the peripheral nerve. The peripheral nerve talks very closely to the muscle, and over time we start to lose the end of these turquoise nerve representations here. And as we start to lose that terminal, the muscle no longer knows when it is and is not supposed to contract. And eventually it's going to accidentally contract. That accidental contraction sends a signal all the way back to the spinal cord that something went wrong, and that signal keeps looping back from the muscle back to the spinal cord, from the spinal cord to the muscle. And this loop of neural signaling sends spasms, and that causes the muscles to get short and short very rapidly. And when muscles get short, they're using energy. And so when muscles get short fast and use a lot of energy, they're going to hurt. They're going to build up lactic acid in them, but also just the shortening of the muscle itself can cause pain because our body knows to protect itself against muscle shortening or lengthening too much. And so what can make pain better or worse? I wish I knew what could make a lot of pain better. We're going to talk about some modalities that can hopefully, if identified, make pain better, but also talk about some things that we can avoid to make pain worse. This is a slide taken from a separate disease called systemic lupus erythematosus, which has some overlap in symptoms with CMT, but is really a completely separate disease. But I think this slide applies to patients with CMT as well, specifically in the middle. We know that fatigue, we're learning more and more about fatigue in patients with CMT. Both from a muscular aspect, meaning the muscles themselves getting fatigued, but also from a whole body aspect, the body getting fatigued, the energy levels not being as high as perhaps some people want them to be. And there's a lot of things that can contribute to pain. And a lot of those things have nothing to do with CMT. For instance, headaches can make peripheral neuropathy pain worse. Having other joint pain or arthritic pain can also make pain worse. And we see in the middle here that fatigue and pain have a lot of overlap. And all the things really on the right-hand side can affect the left-hand side, and all the things on the left-hand side can really affect the right-hand side of this figure. But what I like about this figure is that it highlights sleep and physical activity as two things that are critical for managing fatigue and pain. And when we talk about pain in any type of disorder, pain is often cyclical in some way. Something sets off an injury, sets off something, the muscle not firing the way it should sets off something. You bump against something. This pain leads to a cycle where you may adjust how you walk because you stubbed your toe. And that may cause pain in your ankle because now you're walking differently because you stubbed your toe. And these type of pain cycles are important for us to break, especially in folks with CMT who do suffer from pain. Because unfortunately, at least for now, this is a lifelong disorder that we can't currently make much better. And so there may be times when pain is higher in some folks and lower in other individuals. And so understanding this pain cycle can also help us manage patient symptoms, as we'll talk about just a little bit later. So getting into physical activity is, in my opinion, one of the more critical things that CMT individuals can do every day that may help with pain, certainly helps with strength and mobility, and is something that's generally an important thing, I think, of everybody's routine to maintain the strength, the pain, and the things that they have currently so that things don't get worse. But when we think about physical activity, we just talked about fatigue, we talked about pain, and these type of physical activities can be a double-edged sword. If we do too much, we have a risk of causing more pain, more fatigue, and perhaps even damaging our muscles, tripping, falling, those kind of things. But if we don't do enough, then we're at risk of then we're certainly going to develop fatigue, and we're more than likely going to develop pain on top of that. And this is a nice study done by the Italian group who tested treadmill exercising in patients with CMT. And unfortunately, this particular test, trialing individuals on treadmill testing twice a day or twice a week for 3 months, didn't show much in the way of improvement of pain. It did show some improvement in balance. But what I'm encouraged in is the old adage that if you exercise, you're going to damage yourself in CMT. I think this shows nicely when we compare those who did treadmill, those who did not do treadmill, those who did treadmill maybe got slightly better, but certainly did not get any worse. So being able to exercise and do some physical activity to whatever your limits are can be important for maintaining your current level of function and also maintaining your levels of pain as well. Nutrition as the ABCs of pain by the Hereditary Neuropathy talks about. There are many, and I'll just point out, bring this part of the slide up. One of the snippets from the ABCs is a great takeaway from considering nutrition and neuropathy pain, or pain with CMT and neuropathy pain, that there's no one single food, best food. There's no one single diet that's going to necessarily improve your symptoms or prevent your symptoms, or sorry, improve your symptoms. But there certainly are diets and diseases that we can obtain, or diets that we can partake in that can certainly make this worse. So high glycemic index foods are likely to cause diabetes, and diabetes is very likely to make all neuropathy, especially CMT, worse. So pain is generally more severe, and the weakness is generally more severe. So we want to avoid neuropathy at all costs. There are other things that we take into our diet or don't take in that can exacerbate CMT. So it's important to keep our vitamin B12 levels up and have those checked somewhat frequently if you're not taking B12 to make sure that your levels are staying above normal. It's important to avoid things that have peroxidine or vitamin B6 in it, because those things can worsen this type of pain, neuropathic type of pain. Sleep, I feel, plays a critical role in patients' experience of pain. As we talked about, pain is a very has an emotional component to it as well. And that emotional component is regulated a lot by parts of our brain that need to reset themselves. And those parts of the brain that reset themselves most often do it at nighttime. And starting back in early 2001, a nice paper here in the middle of the screen showed that amongst a family that male individuals who had worse degrees of CMT were more common to have were more likely to have sleep apnea. And Dr. Shai talked about this several years ago, and we're starting to see more and more evidence coming out supporting a type of sleep apnea that may not be best qualified as obstructive sleep apnea, but certainly sleep apnea to the point where there are hypoxic episodes at night with individuals that have all types of CMT. In my current clinic, we have around 60 to 70% of the patients with CMT that we've tested come back as having some type of sleep apnea. And around 30-40% of those patients who start on a device do see improvement both in their fatigue and with those with pain see improvement in their pain levels as well. We see this in other types of diseases like fibromyalgia, and other types of pain disorders where if there is sleep apnea present, that improving the sleep hygiene can improve these symptoms. And as we talked about a little bit here, on the right-hand side, there's a direct correlation with the lack of sleep we get or the lack of quality sleep we get and fatigue. And this is highlighting just basically a cross-sectional picture of folks with CMT, outlining the degree and the nature of fatigue that these individuals feel. And it seems that most individuals tend to have, specifically focused on pain, positive sensory symptoms when they're fatigued, meaning they have burning pain or ice cold feet, as opposed to a loss, numbness type of thing. We often think as numbness as not is really a portion where the nerve no longer is functional at all. Whereas these gain of symptoms are where the nerve is maybe more hyperactive and sending off these abnormal pain symptoms as well. So what are the treatments and prevention strategies? Really, the treatment for most types of this pain, for most types of pain in CMT is going to rely on what you're telling me and how severely this type of pain affects you. And I'll talk about that in the very last slide here. But I did want to point out one last time the ABCs of pain. One of the most common medications that we use, and many of you all have probably tried it or heard of people who have tried it, is gabapentin. And the ABCs of pain has a beautiful write-up about the mechanism, how it works, side effects, and things to expect along the way of taking this drug. But what I want to point out is that for neuropathic pain, which we'll talk about in just a second, oftentimes we prescribe gabapentin, pregabalin, and duloxetine, or combinations of those medications. It's important to remember, as I'm highlighting down here on the right-hand side, that these medications really don't necessarily work on the peripheral nervous system. Gabapentin is working on these voltage-gated calcium channels in the brain. And so gabapentin really is not doing anything in particular for your peripheral nervous system. It's telling your brain to ignore the symptoms that are coming from your peripheral nervous system. And there are certainly people who do well on gabapentin. There are people who don't do well on gabapentin. Some people get a tremendous amount of brain fog, dizziness, swelling in their legs, not feeling themselves, or they may get no benefit at all from it. But I think it's important to keep these type of things in mind. And if your doctor's recommending a medication to you, I would check out this ABCs to understand, one, how it's working, but also two, what side effects you might experience. And so very lastly, I'll just kind of walk through some thoughts about how I manage pain. I think when I try to manage pain, I try to think about pain as being either nociceptive or neuropathic. Muscle cramps generally are a separate type, and they often present very differently. But the very first thing that I approach with all patients, whether this degree of pain is affecting their daily life or is more of a nuisance, is that we try conservative management. Oftentimes, adjusting our daily exercise routine, which may mean adding more, taking away, depending on what you're doing. But it's something that you should have a conversation with your doctor with, and oftentimes I have conversations with my patients about this. Oftentimes that will involve a sleep study, some degree of physical and occupational therapy, considering what we're taking in as part of our diet, and maybe thinking of topical creams, which sometimes have less side effects than some of the oral medications that we have. They also may have a less effectiveness. We don't know. It's never been formally tried in patients with CMT. Unfortunately, if it is continuing to affect your life and you've not doing well on conservative management, that's when we start thinking of adding gabapentin, pregabalin, or duloxetine. Generally, we start these medications slowly, and we may change out pregabalin for gabapentin depending on how you respond to it, and may add or subtract duloxetine to how you respond to it. Oftentimes, I find that the patients that come to me have usually been on these medications for several years. I like to, anytime we start a medication in patients with CMT, especially for pain, is that we try to come off of that medication every year on the anniversary of starting that date or starting that drug, so that we can hopefully not make these lifelong medications. As we talked about, pain is cyclic. And if we can break that cycle, then oftentimes we may not need medication. So I don't oftentimes believe in medication as a long-term management strategy, but more as a short-term management strategy right now, especially given the medications that we have are not targeting or helping the peripheral nervous system. There are unfortunately patients who get much more severe pain, and we can't manage it with these medications. And oftentimes we'll try things that maybe aren't as commonly used for neuropathic pain, but maybe for other disorders, and we may use those in combination with these medications. Low dose naltrexone also seems to have some effect, some additive effect when we use it with these other medications, and when we keep the doses very low, the opioid effects are very, very minimal. Nociceptive pain, though, we approach very differently. We try to figure out, why are you having this pain? So, for instance, individuals that have pain from their ankle having tons of arthritis in it. Well, we're going to try to figure out what we can do to limit that pain. And that may be limiting the mobility in the ankle by using the brace. It may mean we need to do serial casting in kiddos to get that ankle in a better position. But ideally, we're not probably going to use medications all the time for that type of pain, because again, those are often something structural. And we're trying to identify the structural or the compensatory mechanism behind this. Topical creams, though, again, can be helpful for this, especially those topical creams that have non-inflammatory drugs like NSAIDs can be very helpful for this. Cramps, again, a little bit different management than what we talked about before. The most important thing is to identify whether or not there's any electrolyte abnormalities or vitamin abnormalities, and more specifically, electrolyte abnormalities. It's not common in individuals with CMT, but there are inherited nerve diseases where the potassium may get too high or too low. That can cause cramps, but along and other symptoms as well. But it can also cause heart problems. So muscle cramps, we're always checking to make sure the electrolytes are the way they should. Oftentimes, we start with conservative management, and I think lots of people, in my experience, have been able to find a manageable system within a combination of these recommendations here. I don't know if one particular thing works for every single patient, but I do some combination of these can often help with symptoms, maybe not eliminate them, but can help with symptoms. We put tonic water here. Tonic water has something called quinidine in it. Quinidine is a great muscle relaxer. It's no longer on the market or available, but you can get it generally at any grocery store or pharmacy. There are medications that we consider using, and this is really where the distinguishing factor between, the distinguishing factor between spasms and cramps come in. When there is spasms that are involved, and even if those spasms are painful, we use things that are used to treat the hyperexcitability of the nerve. And those sometimes are medications that are also extremely dangerous for the heart and are actually developed as heart medications. Sometimes the cramping is so bad that we have to use those medications, and we use them cautiously. Other medications that are probably more commonly described by your maybe family practice doctor or pain medicine doctors would be Xanaflex or cyclobenzaprine. These, again, don't work on the peripheral nervous system or the muscles themselves. Those particular medications, cyclobenzaprine, Flexeril, as well as baclofen, are working on the central nervous system. But those medications can sometimes symptomatically help, similar to gabapentin, where it may not be targeting the peripheral nervous system, but even targeting the central nervous system can provide us some pain relief. So by way of concluding statement, sorry, I'm a little bit over. I hope this gave you some insights on what you may be experiencing. Hopefully most of you don't have pain, but for those that do, have a better idea of why you may have that. And like I talked about, routines can be very helpful, especially considering stretching routines when we're considering pain and mobility. And that routine should become routine in order to hopefully keep these symptoms at bay for as long as possible. And always talk to your doctor. The more I hear what type of symptoms that you guys are experiencing, the better I understand how to check these things, how to study these things, and how to understand them as well. And that's all I have. Thank you.
Thank you, Dr. Castoro. That was a really informative presentation. We do have some questions from the chat if you have a moment. A few people asked in the chat, what does it mean if you do not have any pain symptoms?
So there's two thoughts to that. Some people with CMT don't have any sensory symptoms at all, meaning the sensory nervous system isn't affected at all, and it's just the motor system. So you may have weakness, but that weakness isn't associated with any numbness, tingling, or pain. So that could be one reason why. The other reason could be, unfortunately, the nerves have degenerated to the point where there's no sensation in that area at all. And once nerves have degenerated, they won't send their pain signals anymore. And so it may be an indication that that area has lost all of its sensory nerve innervation.
Okay, great. Thank you. That's helpful. We also had another question. Once I, or what are, oh, sorry. There are a few that you already answered within your presentation, so I don't want to repeat. One person asked, once I have the diagnosis of CMT, how will I know if I also have lupus or another disorder? I know that's not quite your area, but do you have any guidance on that?
Yeah, it's a great point, and I think it goes along the same way of understanding pain in that not all pain is neuropathic pain, or not all pain could be due to your neuropathy. So oftentimes it's not uncommon for individuals with CMT or any other neurogenetic disorder to have another problem with it. So a rheumatologic disorder like lupus, but they are more difficult to distinguish when you have a disease that already causes pain or numbness. Um, but oftentimes we will see things outside the normal when people have these two types of disease. And what I mean by that is individuals with CMT oftentimes don't get red and swollen knees. People with lupus oftentimes get red and swollen knees. And so there are some signs like that that can help us distinguish the two. But it can be difficult, and that's where I think sometimes being able to describe your pain and understand where it's coming from can help communicate with your doctor what's coming from to highlight, okay, maybe this isn't what I thought it was and could be something different.
Yeah, absolutely. Thank you. Our next question, are there nerve issues that cause chronic coughing?
So there are nerve issues that can cause chronic coughing. We don't have the best understanding as to what they are, exactly what nerves, nor how to particularly intervene on it. But if the chronic coughing becomes severe enough, then oftentimes there are some ways that we can block some of the nerves in order to again reset that pain cycle, or reset that site. And in this case, it's not a pain cycle; it's a motor action that keeps cycling. But again, we're just trying to break that cycle with that particular approach.
Thank you. That's helpful. So our next question, my daughter is 8 and she says her legs hurt at night. How do I know if this is CMT pain or growing pains?
Yeah, that's really difficult question to answer for sure. I would say the chronicity of it, unfortunately, is the best way. So that means how long have they been having the symptoms? If the symptoms happen in short spurts, 3, maybe 4 days, and then are separated by a few weeks to months, and then they may have it again, those are probably growing spurts. Pains that are consistently there day to day and are maybe the same or worse on some days, that's probably more associated with the CMT. It may not be directly due to the nerves being uh, surprisingly more abnormal or anything like that. It may be because they have this disease and they're growing along with it. So it can make growing pains somewhat worse. Um, but I think being able to distinguish the two really comes down to time periods. If it's really for short periods of time and then goes away, that's more likely to be something that's a growing pain.
Okay, thank you. Another question, will starting to wear braces for the feet at an early age help with slowing the progress or the progression so surgery won't be needed or not needed until much later?
Yeah. So there are certain braces and certain ways to prevent those type of things from happening in the future. Um, for instance, but there are certain braces where we wouldn't necessarily want to jump right into it because it could make those some of those symptoms worse or less correctable by surgery. So yes, the short answer to the question is yes. The longer answer to the question is it's really important to have a good orthotist that can help align the braces to prevent things from getting worse. Um, and we don't oftentimes want to jump right into bracing as a preventative way, especially when kids are growing up, because oftentimes they can correct some of the things or compensate for some of the things. But when things continue to get worse, that's when we may consider surgery. There's nothing right now, unfortunately, no great evidence that shows that any one intervention, meaning bracing or early exercise or treating pain, is going to prevent the need of surgery. That seems to be more individualized, meaning each person is different and each disease is slightly different as well.
Thank you. So another question from the chat. What are your thoughts on magnesium for cramps?
Yeah, I think magnesium can be great for cramps. There are some disorders, some types of CMT and some types of inherited neuropathy that specifically affect the neuromuscular junction predominantly. And those types of diseases may see more fatigue actually when they take magnesium. We see this in patients who have a disease called myasthenia gravis. And there are some types of CMT where if you take magnesium, it may cause your muscles to fatigue earlier. Now, that will generally wash out of your system within 24 to 48 hours, and people will generally start to feel back to their baseline. So I think if you're having cramps and mustard, pickle juice, tonic water, all those things haven't worked, magnesium's worth trying, but understand that if you start feeling more sluggish, that could be a side effect of the magnesium for your specific type of CMT.
Right. Okay. That's good advice. Thank you. So we do have two more questions if you have just a moment to go a little over time.
Sure, sure.
Great, thanks. So I've tried to get off gabapentin. I've been on it for 7 years, but I can't tolerate the nerve pain. Do you have any other suggestions?
I think the first thing I like to try is compounded types of medications in those cases. So we can, if you have a pharmacy in your area that can compound gabapentin into a cream, there's also other medications that can be compounded along with it. Some of the medications I listed here before. Um, those those creams can still work on the nerve pain, but without these, I don't want to say addictive, but these kind of reliance types of habits that gabapentin or pregabalin and duloxetine um, can cause. But we see mostly the similar effects, at least with gabapentin and another medication called nortriptyline, when we provide it through the skin than when we provide it orally.
Great, thank you. So our last question, can CMT be in your stomach, like making the stomach muscle itself have spasms causing nausea, or would that be a different condition causing that?
That sounds like a different condition, but there certainly are types of CMT that can have something called a thoracic neuropathy. And if you develop what's called a thoracic neuropathy, is where the nerves from your thoracic spine, which generally don't do a whole lot of muscles, those nerves get damaged as well. And the muscles that they do innervate are our abdomen. And so in some cases, it can be a sign of deinnervation to have or loss of nerves in that area that can cause those symptoms.
Okay, thank you so much. So I think that's all the questions we have for now. If your question was not answered in the chat, we do encourage you to reach out to HNF or to the MDA Resource Center. We will be happy to have someone speak with you and try to answer any questions that you still have after our presentations today. But I do want to thank you, Dr. Castoro. You provided a lot of wonderful information, and I know pain management is such an important piece of this. So thank you so much for your time and for your support of HNF and MDA. So this year marks MDA's 75th anniversary. This milestone has been made possible by generations of dedicated support from people living with neuromuscular disease, their families, researchers, clinicians, volunteers, and donors who boldly drive our mission forward. As we look ahead, we remain committed to honoring this legacy, building on the impact we've made together, and continuing our momentum towards transformative progress for people living with neuromuscular disorders. To learn more, visit mda75.org. Last but not least, we again invite you to join the MDA community. Joining is free and will help you stay up to date on our programs as well as on the latest research. Please scan the QR code with your smartphone or visit the link in the chat. We would again like to thank our program collaborator, HNF, the Hereditary Neuropathy Foundation, and particularly Allison Moore, the CEO and founder of HNF, who presented today. We'd also like to thank Dr. Brian Lynn, Dr. Ryan Castoro, and Shauna Feely for sharing their time and expertise with us today. We had so many wonderful presentations and conversations. And thank you for all joining us as well. And we'd like to hear from you. What did you like about our program today? What can we do differently in the future? Please fill out the brief survey that will pop up right after the webinar. Your feedback is important to us. And if you have any questions or are looking for support or resources, please contact MDA's Resource Center at 1-833-275-6321 or via email at resourcecenter@mdausa.org. This will conclude our presentations for today. Thank you so much for joining us. We will have another session tomorrow at 3 p.m. Eastern Time for our second day of Spotlight on CMT, partnering with HNF. So again, thank you all so much for joining us, and we will see you tomorrow.